Treatment of subclinical hypothyroidism in pregnancy. Subclinical hypothyroidism is a mild form of hypothyroidism where the only abnormal hormone level is an increased TSH but a normal level of FT4. Studies suggested 0.1 to 2.5 as the normal range of TSH values in the first trimester and less than 3 in the second and third trimester. So in this study we have taken TSH value of 2.5 as a cutoff to exclude 2 SCH in the first trimester. Symptoms. This disease usually does not have any symptoms or sign in non-pregnant women, but associated with multiple adverse outcomes in the mother and fetus, including spontaneous abortion, preeclampsia, gestational hypertension, gestational diabetes, preterm delivery, and decreased IQ in the offspring. Causes. During pregnancy, production of thyroid hormones and requirement of iodine is increased by approximately 50% and thyroid gland enlarges by 10% or more. Thus, pregnancy creates a challenge for the thyroid, particularly where thyroid reserve is limited or iodine deficiency is present. That being said, there are lots of situations that cause SCH, such as iodine deficiency, chronic autoimmune thyroiditis, radio-iodine ablation, or surgery for hyperthyroidism, thyroid tumor surgery, congenital hypothyroidism, and rarely lymphocytic hypophysis. SCH has several ill effects on both mother and the baby if goes untreated. Women with untreated SCH are 3 times and 1.8 times more likely to develop placental abrasion and experience preterm labor, respectively. SCH is also responsible for gestational hypertension, whereas 36.1% of the women with overt hypothyroidism develops gestational hypertension. The incidence of low birth weight is markedly increased in the cases of overt as well as SCH. Fetal neurological development and cognitive function can be influenced by the thyroid status of the mother. Women with mild hypothyroidism results in preterm delivery in 80% of the pregnancies, whereas with adequate thyroxine replacement in early pregnancy, preterm delivery can be reduced to 10%. Women in the euthyroid state but with thyroid autoimmunity are twice likely to experience a spontaneous miscarriage, probably due to generalized activation of the immune system or transplacental transfer of thyroid receptor blocking antibodies. There is weak evidence that administration of T4 may prevent miscarriage due to thyroid autoimmunity. Discussion. Controversy exists whether the subtle abnormalities of thyroid function in subclinical hypothyroidism are truly associated with infertility and miscarriage, and whether treatment with thyroid hormone reduces these events. If SCH is diagnosed either by symptoms or by risk factors, insufficient evidence exists either for or against a recommendation for treatment with a low dose of levothyroxine. Universal screening of all pregnant women for hypothyroidism, overt or subclinical, is not currently recommended. Pregnant and lactating women should receive 250 iodine daily to supplement dietary intake. These women should receive 150 from either prenatal vitamins or another source. Conclusion. From the data available until date, is not evident that treatment of SCH in pregnancy leads to better outcome, but some studies believe if universal screening of pregnant women becomes the standard in its recommendation, there will be a huge increase in the number of pregnant women requiring levothyroxine treatment.